is Dr. Pamecha. Yeah, he's going to speak on median sectoral segmental hepatectomy.
Hi, good morning, everyone. Thanks, ISG, for having me here. So what I'm going to do is I'm going to talk about, I'm actually going to present two videos. And, sorry, it's rushing. Can you stop this? Can we start from, can you make a new start? Right from the start, okay. So this is the first case. It's a 71-year-old man with the diabetes, hypertension, had a colorectal cancer, transverse colectomy done 2 years back, and then he had a adjuvant chemo done as well. And then subsequently he was found to have chronic liver disease, NASH-related. It was child's A, and then on follow-up he had a raised CEA as well. So he was found to have a metachronous colorectal liver met in segment 7. So my video is about segment 7 resection, and yeah. So that's the scan. So you can see there is a large lesion in the segment 7, around 4 centimeter in size. It was close to the pedicle as well. So we did a diagnostic laparoscopy to start with, and then this was followed by, so liver is frankly cirrhotic, right lobe was completely immobilized, and the right hepatic vein was slinged as well. So these are the small veins, cable veins on the right side, which have been taken, and the right vein has been slinged. So once we've done that, then we will just do an intraoperative ultrasound to see the basically relation with the right portal pedicle, and also with the right hepatic vein as well, just to assess how far is the margins and where exactly we are going to hit the pedicle intraparenchymally. So after that we will mark, and so the aim is to start with a maybe 1.52 centimeter margin, so that you get an R0 resection. And also when you are doing this type of resection, it's better to get a higher margin, because sometimes you will be actually landing up closer to what you anticipated actually. So again, an intraoperative ultrasound to assess that the margins are okay where we are marked. And then the transection standard with CUSA. So the way it is done, what we do is we'll try and hit onto the pedicle first. So we'll go into the depth onto the segment 7 pedicle, and that's where we will take the pedicle down. So the important thing here is actually the depth of this resection, because these are resections where in order to get an R0 resection, you need to have a good perception of how far you're going to go down into the liver. So that's what we are doing, that we trying to get into the depth so that we can get onto the segment 7 pedicle there. So that's the segment 7 pedicle, and just to put a clamp there to see that we haven't got any other vascular pedicle to confirm it, and then standard clipping, and once we remove the specimen, then obviously we're going to stitch all this big clips. Okay. So once we've done this, then the next thing will be to get the segment 7 veins, and also to get the depth right onto it so that you get an R0 resection. So that's one of the segment 7 veins there, and then there's another one on this side. So this is the large segment 7 vein. So then again, everything which is more than 2 millimeter, we'll just clip it. So that prevents post-operative bile leaks. Also, the hemostasis is good as well with that. We don't tend to burn everything, which I think is not right. Actually, clipping is much better, although it may take a bit of time, but it is much safer as well. So again, taking down segment 7 veins there, and then gradually making sure the depth is right. So in this particular approach, basically you can hold the specimen in your hand. It does help, and it helps in the terms of achieving a good resection margin and on the depth as well, and also in terms of having the transection done. So that's after the transection. And so you can see the right vein is running along the course. That's the photograph of the specimen. And so good resection margin there. And this was histopathologically as well, R0 resection, colorectal met as well. So the second case is a young 15-year-old baby who presented with a progressive abdominal distension of 10 months, and she had a well-defined mass palpable. And so there was no obvious cause, so that's the scan. So you can see there's a large mass sitting right into the center of the liver and splaying out both the portal pedicle on the right and the left side as well. And the mass actually encroaches goes beyond the left falciform ligament on the left side, and it is completely splaying the right-sided pedicle as well. So I'm just going to go back on that and show you again. Sorry. Yeah. So that's the complete splaying of the right and the left pedicle there. Okay. So there is no encroachment, but there is complete splaying of the right and the left pedicle there. Okay. So we plan to do central hepatectomy here. That's the mass. You can see that's the left lateral segment there. It is completely encroaching and also going beyond the falciform ligament. So the initial dissection will be in this plane where we try and take down all the segment 4A and 4B pedicle. So this is, in pediatric, it's better to do under loops all this, which makes life comfortable because you have a better vision and you can. So during this dissection, the important thing is because it's a large mass, so there can be rotation. So you have to be careful that while you are doing this dissection, that you don't go onto the left of the falciform ligament. So you have to be very careful because of the rotation here with a large mass. And otherwise also, whenever you're doing an central hepatectomy or an extended right hepatectomy, you need to be careful that you stay onto the right of the falciform ligament in order to take down the segment 4A and 4B pedicle there. So once we've done that dissection in the hilum on the left side, then slinging the left hepatic vein, and then the demarcation onto the left of the falciform ligament here because this is encroaching towards the left. Then right-sided highlight dissection, standard dissection of slinging all the vessels, right hepatic artery and the vein as well. So this is parenchymal transection started onto the left of the falci there, and so going gradually, nice and slow there actually, you need to be careful. So again, as I said, it's a large mass and it is going on to the left of the pedicle, so you need to make sure that you're not taking the vessels of segment 2 and 3. So that's the segment 2 and 3 remnant there. So now slinging the middle hepatic vein. So the current sling is onto the left hepatic vein. So we try and sling the middle hepatic vein, which we are going to take down. So now the transection from the right side. So this is basically, it was more of a field where exactly the mass is encroaching onto, and then to get a resection margin. So we started the parenchymal transection there. So again, I'll just clip everything which is more than 2 millimeter in size to make sure you don't get bile leaks, and also to achieve a good hemostasis as well. So this is completion of the transection onto the right side. So, and that's taking down the specimen. So this is you can see the pedicle there on the right, on the left side and on the right side here, and the whole specimen has come out. So that's the final photograph. And it's always good to do cholangiograms when you finish with this, so that you know you will not damage any bile ducts, and also if there are any leaks, then those can be checked on as well. So this is the final cholangiogram. Both right anterior posterior were preserved. So this was a mesenchymal hematoma, and thank you very much. Thanks a lot.
I think it's very good videos. If I just start the ball rolling. So in both of these, you did not do any Pringle. There was no Pringle maneuver for the first one as well as for the next one, right?
Yeah, you don't need this actually. You don't need Pringles for this. And personally, I'm not a great fan of doing Pringles unless you need for some purpose. So with the techniques which have evolved, you can do parenchymal transection without actually vascular occlusion or anything. So obviously, if you land up with troubles, there is a venous bleed, and which is getting difficult to tackle, then in those situations, Pringle can help you tie over the situations. So I'm not a great believer in doing vascular or ischemic preconditioning or doing a Pringle maneuver to do liver resections. Don't need those.
So this CRLM, which was there slightly on the surface of it, and if you would have encroached close to this segment 7 pedicle, and you would be interested to take slightly more clearance, then in a situation like this, which is slightly more in the depth but maybe of the same size, will you take still the segment 7 in parenchymal saving, or will increase the segmental resections?
So obviously your resection will be dependent on the size of the lesion and also on the margins you're going to get. So in the current era, it will be more as much as you can save, as much parenchyma as you can save. So the debate about doing a complete anatomical versus non-anatomical resection. So if you can save parenchyma, why not just save it? Okay. And so the size of the lesion and resection margin will be more of a determinant. And the way liver resections are currently being done, you can tackle the pedicles intrahepatically safely, and unless you get into trouble. But most of the time, you will be able to tackle them intraparenchymally.
Yes, Dr. Ramesh.
Yeah, you're audible.
When you have to identify and preserve the right posterior pedicle in a sentinel hepatectomy, and you can't identify it properly before you begin transection, what is your strategy? How do you go about?
So the strategy in this particular case, actually, because it was just playing, so I don't have to take it. But I will, if I'm doing a sentinel hepatectomy, actually, I will sling all the extrahepatic slinging will be done for both the hepatic arteries and the vein as well. Okay. And when you're doing sentinel, so obviously you're going to take the anterior pedicle down. Now there can be situation where there are large tumors and you can't extrahepatically sling them. I think that's where the question is. So I'll just sling the right right pedicle, right artery, right vein, and then we'll start the transection. We'll go intrahepatically, intraparenchymally, and then take the right anterior pedicle down there. Again, that sometime because the way it splays out, it can be difficult, and you have worries about damaging the right posterior pedicle. But I think the way, if you're careful with your anatomy, because right posterior is going to dip down and right anterior is going to curve up. So in that situation, again, you can help with the bulldogs, and you can help with the intraoperative ultrasound as well, that you're not hitting onto the right posterior pedicle. So the whole idea of is to how to save the right posterior pedicle. So those are the maneuvers you can do. And now obviously when you do the bulldogging, you will have the, whether there is a difference in the color or ischemia is happening or not. That will again help you in terms of identifying that you're not damaging right posterior pedicle.
So the problem is when you have the takeoff of the right posterior pedicle well within the liver, in addition to having a large tumor. And then as you say, bulldogging is the only way of being sure what you're encountering. Is that right?
Yeah, intraoperative ultrasound can also help you.
Would you, have you ever found ICG or something like that useful?
Personally, I haven't done it, but because I haven't encountered such a situation as well where I couldn't identify right posterior pedicle properly intraparenchymally and not being sick. But I agree with you that ICG might help as well, or a simple cholangiogram can help in that situation as well. So, you know.
ICG with a marker. When you have reached the pedicle, you want to know which side you are in, and it would help.
Marker cholangiogram, like we do in the donor hepatectomies, that can help as well.
There are no more questions, then Dr.
Thanks.
Vivek, the next speaker. Thank you very much.